Wonderful.
Uh-huh.
Great. Hi, everybody. My name is Molly Coleman, and I serve as the St. Paul City Council member representing Ward 4. And I will pass it to my left.
I'm Seneca Kruger. I am a community impact manager for community medical services. That basically just means that I do a lot of street outreach and other things, trainings, things like that. But yeah, excited to be here. Thanks.
I am Kat Donnelly. I'm a family nurse practitioner with Healthcare for the Homeless here in Ramsey County.
Hi, I'm Tatiana Finkley. I am the executive director of a local, soon-to-be-open recuperative care program in downtown St. Paul, and here to talk about the intersection between housing instability and health instability.
My name is Kyle Lipinski, and I use she, her pronouns. And what I tell my clients is that I have a bunch of letters after my name that make me look really good in court. But I'm a licensed professional clinical counselor, a licensed alcohol and drug counselor, a certified brain injury specialist, and I've been working with unsheltered folks for the past 10 years.
Amazing. Thank you all again for being here today. So I want to start this conversation off very high level. I want to hear about what you all have seen that is working when it comes to serving our unsheltered homeless population in St. Paul and surrounding areas, other places where you have worked or learned from, and what isn't working. Where do we have opportunities to improve? I think one of our goals in this conversation today is really to think about what should we be building towards, what infrastructure do we need to be building, what resources do we need to be investing, and who should we be learning from. So yeah, like I said, I will keep it really broad. What's working, what isn't working?
Well, I guess I could jump in. My experiences in working with just different programs between housing, shelters, drop-in centers, organizations that are doing this work are so well-intended, right? I think all programs, hospitals, cities, everyone has their well-intended purpose of what they want to accomplish, but getting the collective to work together, because when we think about individuals who are unhoused, they don't experience health instability, housing instability, homelessness separately. They're experiencing it all at once, while our systems and programs are designed and they're working separately with good intention, but it doesn't seem to be giving us the outcomes that we want. So we have great people, as you can see here, doing this work, working really hard at it every single day. I think just the intentional collaboration and infrastructure for the continuum.
Yeah, I really agree. It has been one of the most effective interventions that I've been a part of is that collaboration between agencies. I often when I go out to the encampments, I go with an outreach partner, either with Radius or 555 or with Community Medical Services or with the Aliveness Project. Going out in conjunction with another program that does slightly different services is so much more powerful. You can't carry I liken it to like the Mary Poppins bag. You can't carry everything in one bag. And you can't offer every service yourself. And so it really allows me to stay in my lane. And we've had a lot of success that way. We have really managed infectious disease in the camps very, very effectively with this collaborative model. And Ramsey County is doing that really, really well. We meet weekly. 60 plus providers meet weekly on a Teams call. What are you seeing? What do you need? Who can help you with that? What other resources are available? What do you have upcoming? What does your organization need? And so working collaboratively has been, I think, the thing that has increased public health in the encampments the most. Working with Minnesota Department of Health, the disease investigators, and 555 with their mobile clinic has been a really effective way to reach people throughout the day, throughout the week, throughout the spectrum of readiness, change readiness. And Yeah, we've had a lot of success that way in getting people identified, diagnosed, treated, and then completing that treatment. Because often one of those steps is missing otherwise.
I also think one of the things that's working really well is that we're keeping people alive and improving their health in a really incredible way. And I think, harm reduction services and the ways that people are empowering each other to take care of each other and acknowledging their own expertise in this is really powerful. And that was one of the things that was actually really hard to sit with in terms of conversations around the encampment. There's all these conversations about drug use and the overdoses, but, in the folks that I'm supporting, they are still alive because they were there. I know of at least the folks that I've been in touch with, they've survived 8 overdoses because of the fact that other people are around, and those numbers don't get credited because those don't fall cleanly into systems. And so what people are trying to do is empower people to take care of their health and have conversations. I think the hard thing is that we haven't really been able to breach a bigger conversation about the difference between being uncomfortable and unsafe. You're uncomfortable with the way this looks, but these folks are determining safety for themselves and actually providing it for each other. And that piece is the piece that's been missing in all of this dynamic.
Yeah. I will echo what everybody else has said, right? This, as a person who works on both sides of the river, right, in both Minneapolis and St. Paul, I can say that this Ramsey County collaborative that we have here is a really special thing, right? The way that we are able to connect with each other and really support each other kind of across all of these different kind of provider agencies, it is really special. One of the things that I want to highlight too, that I don't think we have talked about is, we're talking a lot about sort of what works for our folks who are still outside, who are in encampments, or who are kind of part of camp or who are part of, unsheltered communities. But the collaboration doesn't stop there. One of the things that I think, and my specialty is working pretty specifically with folks who are unsheltered and using drugs. And one of the questions that I get all the time is, how come we can't just get people into treatment? Why can't we just make them stop using? They don't want to, they're lazy, kind of all of those awful things that we hear. And what the folks tell me when I'm working with them is, using these drugs is keeping me alive, right? And so when we talk about harm reduction, using drugs is also kind of a part of that harm reduction. Right. And I always say, I don't want to take that away until we have something else to put in that place. Right. And so a lot of what I hear is I want to do things differently, but man, I need a house first. I need a door that locks behind me. Right. And as a therapist who specializes in trauma, I understand your nervous system needs to relax before we can even have a conversation about anything different. And so I think those, when we talk about Housing First, and I know the Housing First programs have been under attack lately as well, but they are essential to this work that we all do, right? And then those partnerships, being able to come in afterwards and say, okay, baby, your system is a little bit settled. Now let's have another conversation, right? That's really where those conversations start. They don't start on the street and they don't start in encampments, right? They start when people have a door that locks behind them.
I also just want to say we have the data to support exactly what you're saying. The Mendoza report, which is the Minnesota Overdose Surveillance Report that is, put out, actually says, they monitored folks in ERs and they found unsheltered people are more likely to have successfully completed treatment in the past than housed folks. The thing is, they know that there's not housing on the other side. And so it's actually safer for them to keep using as opposed to be in a space where they lose their tolerance and then they go back where? Back where they have to survive. And so people are actually making practical, informed decisions that are in their best health. It's just this conversation where when we talk to folks who are not used to being in these spaces and having these conversations, I think what people want is a simple answer. And there's not a simple answer to any of this. And also, having to recognize that shelter or treatment is failing when that's the solution your brain has is a hard thing to sit with. And I think a hard thing for people to even sort of rectify in their own minds. And that's kind of also what I've just seen in the comments is like, go to treatment. Well, treatment ends. And then where do you go?
There's so much here that I want to make sure we come back to. And one of the places that I want to get to is, Kyle, exactly where you just took us, which is that people are making logical, informed decisions about how to best care for themselves and the people in their lives. And just because that doesn't look like what some people want it to look like doesn't mean that they are not behaving rationally or again making very, very informed choices. And so understanding that, and I think that really comes back to this notion of being uncomfortable versus unsafe, and sort of the ways that we can project what we want people's lives to look like onto people who are building the lives that they can in the situations that they find themselves in. Tatiana, it looked like you wanted to jump in.
Well, Kyle kind of started on another thing that I thought that we do well. In Minnesota, we collect a lot of data, right? So we have the Wilder survey that really captures the experience of individuals who are experiencing homelessness. We have the homeless management information system that's intended to collect data about individuals from the time that they enter homelessness and track kind of the success of programs. We have the point in time count. So we're doing great at gathering this data. I would really like to know how are we really tracking outcomes, and how is this data being used to improve the lives of the individuals that we are collecting this data from, especially from a data justice standpoint, right? Because we're asking for a lot from individuals. And what I find is every time one of these things come around, an individual, they want to participate, but they're like, I do this all of the time and nothing has changed for me. So data and how we're handling data, what we're doing with it, and how do we utilize this to actually improve operations in programs that currently exist, and how are they making change in policy for the population?
Making sure that we are actually being data informed is an important place for all of us to start. I want to go quickly. Both Kat and Seneca, you mentioned the Ramsey County Collaborative and the weekly calls and who's at that table. And for folks who maybe are less familiar with those calls, would love to just hear a little bit more about what that is, who's there, who runs it, and kind of how you all have seen that be effective in the work that you do.
Sure. So it's been a rotating host. It's currently between two people, one of whom works for Coordinated Entry and one of whom who works for Familiar Faces. Excuse me. And it's about 60 providers right now, and it runs the gamut. It really does, of who's there. The Animal Humane Society is there. St. Paul Probation is there. All the city teams are there. Healthcare for the Homeless is there. 555 is there. MDH is there. Who am I forgetting? Seneca's there.
Yeah. Shelters.
Yeah, all the
are there.
shelters are there.
Drop
Gospel-
in.
Yep, the drop-ins. So Listening House, the Gospel Mission, Catholic Charities, all the outreach folks, Radius, and Vivo Path just started coming. Aliveness is there. Streetworks is there.
We even have some Hennepin County providers that come on to just kind of keep updated on what's happening in Ramsey County.
Mm-hmm.
And hospital social workers do have the invite because I've extended it
Yes, yeah.
quite some time. And I think when we were on this call, it really is real. We're serving the same community, right? And that's where we're trying to close gaps. Kat will come in and especially I believe like one winter, it's like we have seen an increase in, was it like individuals, I think that were using propane tanks or something.
Yes.
And so some poisoning. that
Talking
was
about
happening.
carbon monoxide poisoning. And,
Yes.
Yeah, and
And-
safety tips.
I remembered an increase in measles within shelters. So this is a way for providers to be informed about what's going on in the community, because there are gaps, right? A lot of the times programs are busy and you're kind of living in what is going on. So this is a way for us to kind of convene and say, this is what we're experiencing with the community. And we're sharing information and also coming up with ways that we can improve the current systems. Winter warming centers. We've all been able to have huge voices in what Ramsey County winter warming centers look like and where to pick people up, where to drop off. This gives you the opportunity to step up and say that you can help and support in different ways.
And it's also a little mutual aid too, right? We just got 1,000 socks. Who needs socks, right? I mean, that's a really important thing when we're talking about budgets and budget cuts, right? How are we sharing not only information, but also stuff?
Definitely. And I think it also increases, so like when the warming shelters open, if they hire temporary staff to staff them, do those workers know how to reach out for help? If they're suddenly seeing people coming in with frostbite, do they know how to get a hold of me? If they're suddenly seeing people who need clean needles, how do they get a hold of harm reduction? You know, if they need connection to MNsure navigators or coordinated entry, how do they do that? It's a good entry point.
I am making note of the fact that my first question was about what are we doing well and what are we not doing well, what is working and what isn't working. And we really started with a lot of things that are working and that we are doing well here in St. Paul and in Ramsey County. And I think that's notable. And just hearing all of the organizations that were listed of people who are on a weekly call to talk about how we are supporting our unhoused residents and unhoused neighbors, I think that it is so easy to have this conversation from a deficit mindset of, well, St. Paul has no money and Ramsey County has no money and the state has no money and everything is stacked against us. And there are big challenges, and I want to make sure that we're really clear-eyed about what those challenges are and what hasn't worked in the past. But I do think that there are so many ways in which we are resource rich, and the fact that we have so many people in our community who are doing this work day in and day out, and not just when it starts to make headlines, is something that is really special about our community and something that we, as we look to what does the future look like, need to remember to be accounting for all of those assets. So I appreciate that that is where everybody started. I'm going to push us a little bit, not to get negative or not to point fingers, but to talk about what are the challenges. Why have we have amazing service providers, we have some level of coordination happening, although we recognize that more coordination is needed. And we still have a number of folks who are not housed, who are not getting the services that they need, who are not getting the care that they deserve. Why is that? What isn't working? Or where can we improve?
St. Paul is not the only city coping with people living outdoors. I think that's a global issue. It's what hasn't been working well is that every single one of those services that we listed is oversubscribed and underfunded. Like the clinic that was at Dorothy Day at St. Paul Opportunity Center just closed at the end of June for financial reasons. That's a clinic in a shelter, in the biggest shelter in St. Paul. And there is not another clinic in downtown. And so a lot of people are going to flood the emergency rooms now and get emergency level care, which is what they should be doing in the emergency room. But it's difficult to find someone to fill that gap. It's a unique medical specialty to do healthcare for the homeless. They have conferences about it. You know, it's a niche, and the same with a lot of different services. You know, Radius, mental health case management, are trying to find outreach workers. You know, it's a constant struggle. The staff turnover in a lot of places is very, very high because burnout in this work is incredibly high. The salaries are not high. And sorry, go ahead. I saw you thinking.
I think that is so huge. And the other thing is I also think of the unsheltered population kind of as like a canary, if you will. when we think about things that are not going well, there's a lot of conversation about automation and then also even AI in this conversation. But, 5 years ago, we were talking about the fact that people were now not doing their background checks anymore in mom and pop spaces where people could be housed. They were automating it out to other companies. And so now I have people who are being rejected from housing for a charge, not a conviction. And so that is also something where, as an outreach worker and someone who is doing this work, there's things that we used to be able to negotiate. Hey, this person was really struggling, but look, they're doing really well. They're taking their medications. They're engaging in healthcare. And they have been sober for this many months. Can they live in your property? And people would say yes. We don't have those workarounds anymore. I think the other piece is that in this community, relationships are currency. And so what's so important is the collaboration. Like my friend Kat is going to come and take care of you. I trust Kat with my life. I know she will take good care of you. And that dynamic is something that Kat was talking about when there's so much burnout. This person and I were working on this, and all of a sudden that person is gone. So I have to trust you again. And that relationship, that currency that we had, that connection is no longer there. When I talked about, unsheltered folks are notorious for missing their appointments. And I sometimes, when I was working at the shelter, would see people walking across the courtyard on the way to my office, and then they would be sidetracked. And I was like, you were so close. And the thing to remember is that the reason they were sidetracked is because that person who's helping them in that moment has kept them alive in the past in a very real way. And so I'm secondary until I can prove myself to be useful, because survival is going to be paramount and it's going to be first. And so when we lose those connections and that ability to be seen consistently, like Kat was saying, we lose the currency, and then we can no longer engage in this world that's really separate. It's not the same sort of dynamic. It is like the only thing I have is my reputation. And so I'm going to preserve that. And I need your reputation to match before I can even engage with you.
And Kyle was talking about the unsheltered population as a canary in the coal mine. And that analogy is so true, especially when you're thinking about the overall ability of someone to find a place to rent or to find a place to buy is very, very difficult for most people of this generation. And so when people talk about they don't want housing, I would challenge a lot of people to live in the places that we ask people to live in when we're moving them into housing, especially for the first few times. And it can be a huge challenge to live in those spaces for a lot of reasons. There's a lot of other people living in those spaces. There's a lot of the business of living next to people, the noises, the smells, somebody experiencing crisis, behavioral crisis, mental health crisis, interpersonal crisis, all in very close quarters. And so if you're going to put that against a quiet tent in the woods, people will pick having their own space, having their autonomy.
I think, Kat, you bring up a really important point too. When we talk about the need for housing, right? Housing, I will say housing is the answer. But choice and autonomy are really important to people. So it's not just, here is an open spot, you get this spot, or you may sit on the list for another year. You take it or you take your chances. That doesn't work, right? People need choices in their housing too. And what works really well for somebody doesn't work well for somebody else, right? Some people want to be in a specific area, others don't, right? We don't just need a choice, right? Again, people have preferences and they need to be able to have those, especially when they're looking at this place that they are going to live, And
that extends to shelter. When we talk about the barriers to shelter that people face, and the common reasons are, I don't want to leave my partner, I don't want to leave my community, I don't want to leave my pets, I don't want to leave the areas that I know well, I know where everything is. And extend that to, if you're a housed person that hasn't been around the unsheltered community, just extend that to yourself. Would you like to move to a strange town where you don't know anybody, you don't have your partner, you don't have your pet, you don't know where anything is? Does that sound appealing? Absolutely not.
And Molly and I talked about the kind of diversification of shelter and housing and this one size fits all model. One of the challenges that couples experience, or even a person who has a trans identity, if you go into a single adult shelter, it is male or female. And if I am married, I am now a single individual and I cannot occupy space with my partner. So when we're thinking about these models that we're building, a husband and wife that's a family, and they don't need to have a minor child. Why does that dissolve the moment that they become unhoused and now they're these separate entities? If I am a trans individual, yes, we give you the option to choose whichever side you feel more comfortable, but then there are other barriers that individual may experience where the other individuals in that space then may make them feel unwelcome. Like, how are we supporting different populations with different needs? And so if I am trans and I don't feel comfortable in either one of those spaces, I'm going to stay outside. If I'm a couple, I'm more than likely going to stay outside. Right now, when Hennepin County recently did their RFP, you have to have a plan in place for those needs. And you have to have a plan in place for if an individual has a pet, not a permanent support, like a service animal or a companion animal, or ask someone to start their relationship with you with a lie by wearing that little service vest that you get from Amazon. Which you see so many of them walking around, right? And again, this is what I need to do to keep my pet. Recognize that this is their pet. They need their pet. What systems, practices, processes, policies do you have in place to ensure that happens? And I am living truth to tell you that there are supports out there. Catholic Charities right now is going through a fellowship. My Dog is My Home. That's a fellowship that I wrote. I found funding through Red Rover. I was able to order crates with a grant through Feeding Pets for the Homeless. There's so many entities. Humane Society is at the St. Paul Opportunity Center. I think it's every other month, providing wellness checks for pets. So if you want to make a breakthrough with the population that we're serving, think about the things that they care about. They care about their pet. So if you're making the effort to care about their pet, their spouse, maybe they would want to engage with you in a different way.
I think you bring up a really good point, though. I think we're talking about special populations, right? We need to talk about families. We need to talk about the fact that there are 71 families on the wait list right now, which is over 200 minor children waiting for shelter, right, in Ramsey County. That is an issue, right? We're talking about encampments, but we have a real issue with family shelter. We have minor children waiting for shelter. And we need to talk about youth, right? We need to talk about the youth shelters and what those look like and how they are not working for the youth that we are serving, because there is this idea that youth need to be parented, and they are these sweet, little, gentle, lovely characters who need just a hug and a mom, and that is not true. And the systems are built for youth coming in like that, and the youth who are coming in are the youth I'm working with on the street. They have lived outside. They have been through incredible traumas. They are using drugs, right? And the shelters, these youth shelters, are not built for the actual youth, right, who are needing those spaces. So I do think there is, and I am seeing an incredible amount of youth on the street right now, right? That is that population between really 12 and 24 years old. A huge number of youth, and that number keeps growing. And so I think that those are conversations we need to also be having, right? What does our unsheltered youth population look like, and what do they need specifically, right? As both vulnerable people, extra vulnerable to exploitation, and also people who are very much adults.
Tatiana and Seneca, you've both taken us exactly where I want to go next, which is what does a robust ecosystem look like and what are the unique needs that we need to be accounting for and how do we build housing, build opportunities that support those unique needs. Before we do, I just want to underscore one of the points that you made, Tatiana, about how we almost ask people to start their relationships in some instances with providers or with new housing options with a lie. I think really feeds back into something that Kyle said about how trust is everything and how important it is to be building trust. And if you start a relationship saying either screw your pet or lie to me about your pet, or I'm going to force you to immediately choose to identify with a gender that might not be how you identify, or I'm going to tell you that your family doesn't count as a family anymore. How would you ever build the trust that is needed? And how do you come back from that? I don't think I could come back from a relationship in my life that started like that. And the fact that that is what we are asking people to do speaks to me to a much larger problem. And so gets into this question of what do we need? So Seneca, you mentioned housing first models. Tatiana, you have educated me so much about recuperative care models. I want to hear from you all about what do we need? What does an ideal youth shelter look like, or housing for a 13, 14, 15-year-old look like who has been living on the streets? How are we not, we know that a one-size-fits-all model doesn't work, but what models do work and what models should we be investing in?
Low barrier healthcare and low barrier shelters, I feel like go hand in hand. Coming from a place that is not of judgment, is not of requiring people to lie, to access those spaces, is the only way forward. If people feel shamed, if people feel judged by coming into those spaces, it's a 180. When people are already living outside, they feel those judgments so acutely. And so if you're coming to them with an offer of housing, of healthcare, of treatment, whatever it is, it has to be coming from a relationship, a consistent, reliable relationship. And you have to be telling the truth about what you're offering. You have to not promise things that you cannot give.
And I think one of the things is that a lot of their relationships with housing also start at a loss because we combine benefits. So, I have a lot of folks that are not born in the United States that I work with and I support. And a lot of housing opportunities mean your food stamps go away and you can't cook for yourself. So now all of a sudden you're eating foods that don't make sense to you. There's no cross-cultural awareness or language accessibility in this moment. And so one of the best places that I've been able to support people into is DRH housing that actually allows them to cook for themselves, which is a very simple model. We are going to allow you to buy the food that makes sense for you. You can build a community. You're going to eat together. But that means we also have to radically trust this group of people to make decisions for themselves. And so much of what is available as a first step is going to say, we're going to cook for you. We're going to provide these meals for you. We're going to do this because you are untrustworthy. And that also means that we are prioritizing food that's simple to make, easy to make, that is mostly Western. And so none of it is cross-culturally informed. And that also makes it harder for folks to buy into spaces. There's a lot of spaces that people could really benefit from, but they're going to have to give up their Social Security. So you have no ability to have disposable income. You have no ability to do anything remotely pleasurable. Even if it's smoke a cigarette, you deserve that. And so there's all of these dynamics that become subtraction games for people. And that is also something that we really need to look at to say, okay, so we're going to help you pay for your housing, but we're still going to give you some money to be a human. I know that I went out yesterday and I bought breakfast because I just wanted it. Did I have food at home? Absolutely. Did I have coffee at home? Absolutely. But I had done something in the morning. I accompanied someone to the Whipple building, and that was really stressful for me. And so I just needed a little treat. So do other humans. But when we say you are worthy of this, if we get all of this, that becomes a huge problem.
I'm going to reach back to something that you touched on, and I know that we've talked about in the past, which is language
Mhm.
and access to interpretation. We've talked about spaces that offer services and only in English, or they offer written instructions in another language for people who do not read.
And I mean, I would love to hear this from you, Tatiana.
So to piggyback off of what both you and Kat said, right? The culturally specific part is completely missed. We we don't support individuals from a strengths-based position. We work under the assumption that we know best for the individuals that we're serving. We rarely ask what their needs are and what would best suit them. So then we build a system that is not ideal for what they want. Um, and then we also programs are not funded well, underfunded. You will get initial dollars to start up, but then organizations are then spending all of their time trying to figure out how we're going to fund it another year. So operational dollars don't continue. So then you may not end up with the right size staff to support the population. But going back to that strength-based piece, we say that we give choice in services, but a choice of this or that. There's no choice for that they had input in. And the people that we serve have had way more years of experience navigating these systems than we have. I can share an experience of running the Opportunity Center where the free phone programs went away, right? And we as providers had no way of how to get a phone. And clients were bringing other clients on University Avenue and connecting them with resources. They know more resources than we do. They know how to navigate this terrain. Why aren't they brought to the table to have a say in what housing and shelters and drop-in centers should look like? And recognizing that they have value and their experience is valuable. Another area with that is many organizations. So the DHS background check is another area that it impacts our ability to serve populations. We can't get people into work, but then it also continues to criminalize the population that we serve with lived experience, that they can't enter the workforce, even the workforce where they may be more valuable. There are many ways that our guests at a lot of our shelters and drop-ins want to be able to come in and support and work. And why haven't we looked at any workforce creation for the people that we serve? We can't act as if everyone doesn't want to work. I have many guests that were in my shelters that got up and went to work every day in anywhere that they could be hired. So how are we, again, building programs for the people who need them with the intention of helping them go from here to there? And I have not seen that. I have seen programs being built out of necessity, reactive, out of a need, and I'm not going to say poorly implemented, but implemented with the resources that were available that don't always seem that they're meeting the need of the population.
Yeah, I mean, I think the other thing is the amount of knowledge a provider has to have to get someone housed is so significant. I've been working with someone for 2 years, and the most recent thing we did was a set aside to get this person a job. But to have the knowledge of the criminal justice system to say, we can set aside this conviction, and I am willing as a licensed professional to vouch for you, to say that you've been rehabilitated, which is, first of all, unnecessary. I think this person's work for themselves is huge, but there's also just this liability culture for professionals who are unwilling to do that. And so in order just for this person to be able to care for their grandfather, which is their grandfather's choice, and it's a theft charge, it's not person-based, but even if it was a time when this person was not doing well, it was 3 years ago now, and it's still discriminating against them from being able to move forward. But we had to do the work to get this person first to trust us, to then get inside, then get into treatment. And then, when their background discriminated against them from being able to stay with their family in housing, find a GRH provider that would be able to take them. And then they came back because they needed help with the set aside. Because they couldn't pass a written test for the other job support programs that now have barrier to enter because the grants need people to be successful. So the job support program we'd referred them to needed the ability to read at a grade 6 level and pass a grammar test. I don't know why that was necessary to be a mechanic, but it was. And so then we had to keep pivoting, but the ability to do that and know that is way too many skills for one professional to know.
I just want to echo sort of what Kyle and Tatiana, what you have just said, is we need to trust people to know what's best for them, right? And they tell us all the time. It's these systems that get in the way, and sometimes it's our own egos as providers that get in the way, right? One of the things that really stood out to me when I was in that first city council meeting around when a lot of the camp community residents were in talking was that they had really good solutions, right? They were coming up with these incredible ideas and they were sharing them with all of us. And again, back to this data, where does it go? We ask you what you need. You come and you tell us what you need because you are the expert in your own life. Then what do we do with that, right? There was somebody who was staying over at the Lorient in camp community who said, "You're talking about tiny homes. Bring us wood. Teach us a skill. We'll build our own tiny homes there if you just invest in us." And I think about that, right? Like, what a great idea. Yes, come in and teach us a skill and provide us, right? We have to be listening to those things. We have to be listening to people when they tell us what they need, right?
One thing that I've thought about a lot is over the course of this public conversation in the last month is how so much of what we heard as a council, what we've heard as a city from folks who are living in camp communities also aligns with the data that we are collecting and aligns with what we know about best practices and how there is, again, I just keep coming back to, there is a wealth of information, and information does not make solutions easy. It does not magically fix our budget challenges or anything else, but we have answers. We have ideas. We have no shortage of people telling us, data telling us what should be done and how we can do it. I think that there are questions of will. I think that there are financial questions, but we can set that course. And I appreciate you bringing that up.
I think about that all the time because what we know is the evidence-based solution for supporting people who are using meth is to pay them to stop using meth. I say it like that, and everyone is like, "Ooh, Kyle." It's called contingency management. You do it all the time when you're potty training your kids. They get a little reward if they are, successful in going to the bathroom. But the idea then is actually, if I'm giving you this reward in this moment, I then am pairing myself as the dopamine release in your brain. And so then we can slowly reduce the payment, and then therapy becomes the reward. And so it is something that is evidence-based. We know it's best practice. It works really well. It makes people uncomfortable. And so we don't implement it. The state of California changed their Medicaid laws so they could implement it in a really successful way. I mean, the last administration's SAMHSA had actually increased the amount that we could use to actually have this work. And it is something that's incredible, but it's not implemented because it makes people uncomfortable.
Other people, not the people that we're getting.
Not the people that we serve.
Yeah.
And when nonprofits and entities are doing this kind of work, their donor base and their donor base opinions have a lot of weight. in the lives of the individuals that we serve, which we appreciate your donation. Trust that we're doing the right things to do the work and to do it well, and we have methods that are going to be successful. So I think that's a continuous challenge too. That funding piece right now, um, there are a lot of issues with funding that require unnecessary data to be collected, which then becomes a deterrent from people wanting to access services at all. Some individuals are afraid to use providers now because of things that are going on in the current community, ICE surge, things like that. But yeah, those funder issues, that's a barrier to delivering services. With all of these expectations that are put for data reporting, yes, we want to be able to show success in the programs, but this can't be what we spend all of our time doing. And I think that is what ultimately happens when individuals are accepting funding from many sources.
Pat, I know you have to run, so
Sure.
I just want to give you an opportunity, if you have one more minute, things that you want to make sure to share.
I have a bit of a non sequitur that I wanted to be sure to mention, which is pregnant people.
Mm.
I'm caring for 4 pregnant people right now and doing their prenatal care in the encampments. And they are on the wait list for shelter. They're on the wait list for family shelter so they can stay with their baby. And I've got one that's about to deliver in about 3 weeks, and we're still on the wait list. And we're just hoping that by the time she discharges from the hospital, a spot is available. But as Seneca pointed out, like the wait list is significant. And she has made all the right choices, all the right actions. And, you hear, if you go to any comment section of any article about the events of the last 5 weeks, people criticize unsheltered people for get a job, get a house, just stop whatever you're doing. She would love to. The other people that I'm taking care of are very invested in the health of their unborn child, would love to be eating healthy food, would love to be in a safe environment. Just wanted to bring that forward.
Really, I appreciate you bringing that up, and it makes me think so much about one of the comments that was raised before the city council during one of our public hearings, where somebody told about their experience being called in by somebody they had built a trusting relationship with, who was living in an encampment, who thought that they were having a miscarriage and needed miscarriage care. And they, by bringing in a host of trusted individuals, were able to determine that this individual was not having a miscarriage and was indeed still pregnant, and they were able to get them the support that they needed. And the woman said that had she been on her own and not been able to get that support, she would have assumed she had a miscarriage and she would have started using again. That the reason she wasn't using was because she was pregnant and she was so invested in the health of her child.
Mm-hmm.
And that story, it really stuck with me, thinking about how important it is that we are providing comprehensive support for people who are doing their very best to take care of the next generation.
Yeah. It is, I think, a well-known fact with this crew here, but so many women use methamphetamine as a way to stay safe, as a way to stay awake, as a way to keep their bodies safe as they live outdoors. It's so common.
And another challenge with the population that we serve seeking immediate medical support is many feel, especially if they've had a child taken from them before due to drug use, many are afraid that if they go into a hospital and they're, they may not be clean, or if they are clean, but because of their history, their child is now in danger of being taken from them. I know that has been a huge barrier for for pregnant moms seeking services. This fear that their child is going to be taken away from them right away.
Those are a lot of the conversations that I have on the street with folks who have found out that they are pregnant and will say to me, the first thing they will say to me, because they think that that's what they need to say, is, I'm going to stop using, right? And we know that and it's great because it gives me a little time to give some education. But we know that for pregnant people who are using fentanyl, right, stopping or detoxing on their own, all of that can be really, 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 really dangerous. And so, right, but that is the, I'm supposed to say this to you, right? I'm supposed to say, this is what I'm supposed to tell you. And I go, no, 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 no. Actually, let's not do that, right? Let's make a different plan that is actually going to be safe for the space that you're in right now. But again, coming back to this, people think they have to lie to you, right? And that's tough because it keeps us from really being able to do our best work and helping people keep themselves safe.
And that may be experience because there are some programs. There are some programs who require sobriety to serve and support. And so I think that may also be a survival skill for the for our demographic.
Yeah, there is actually a kind of trauma called intergenic trauma, which means that you've been harmed by therapeutic supports or people who are trying to help you. And when I think about the way that treatment is directly correlated to the carceral system, as well as the CPS system, it's not actually prioritizing honesty. We can't sit and say, okay, so you've had so many positive drug screens, that means you have to go to the next level. When we actually know that a lot of times what happens is that use is a way of regulating attachment. We actually can look at it as an attachment disorder because the only way I'm able to successfully control how I feel is by using. It's been safe, it's been consistent when people haven't been. And I think one of the things that's the biggest tragedy that is the most complex is we are now in a space where we have multi-generations of homelessness. Our mentors have worked with your grandma, your mom, and now we're working with your kiddo. And so the cycle hasn't been successfully interrupted. And what actually is worse for babies, as opposed to in utero drug exposure, is actually poverty and instability. But the hard thing to sit with is that that's a systemic problem as opposed to individual choice. And individual choice is more comfortable for me to sit with so that I can keep a distance from that and say, I'm doing everything right and I'm coping, as opposed to acknowledging the system that we have right now is failing people. And my comfort is dependent on this system as it is now. And so I'm unwilling or unable to examine it.
Another thing when I think about that kind of coordinated response, right? Health, shelters, behavioral health, city, municipalities, like who is responsible for what, or how do we share information in a useful way? One of the things that I get a lot of, I think I still get those phone calls, I just stopped answering them from certain hospitals. So the HMIS, Homeless Management Information System, usually holds information about the guests that we served, contact information. And I continuously get phone calls about an individual with a non-recoverable injury. That means that they need a next of kin to make decisions for, what's going to happen to this individual. And hospitals do not have access to that system because they don't receive any HUD, federal or state funding. So we can't share that information, or they have to contact me to get it in a different way. How do we create a system that we can share that information? Because when you're unsheltered or unhoused, you touch all of those systems, right? You touch the health system, the shelter system, the jail system, the behavioral health system. Like, we operate separately, but there is no mechanism for us to communicate with each other. Another thing that I've been talking a lot to hospital social workers, when everyone, I think, goes to the doctor now, they ask you these questions about social determinants of health and, are you feeling safe? And do you have housing? And social workers don't really know how to address the housing question. They told me that they are just giving them information to go to Housing Link. That is what they are giving. why? Why would we take that on? This is where different organizations need to be collaborating with how to support that. And that's why I still feel that hospitals, cities, we all need to pay into a system that supports the unhoused community and the unsheltered community.
I mean, I think one of the things that we're talking a lot about under the current administration is sort of institutionalization again. And there's actually more beds and institutions than there were at peak institutionalization. We've just outsourced them to different agencies, is what Tatiana is saying. You know, sure, we don't have the psychiatric beds and they're not locked in, but that's now an intensive residential treatment program. That's now a substance use treatment program. That's now a group home. And so there's all these different spaces that people have been, but we don't have any longitudinal access to try and say, like, hey, what could we do differently? You know, we have unsheltered people who hop the river. So they're coming from Minneapolis. And as someone who does substance use assessments, people will be like, can't you just look in the system? I did one 3 days ago. And I absolutely cannot because of the fact that the system is not integrated. I can't say, hey, you came to St. Paul and you don't have a bus token to get back. I can't unless you sign this piece of paper and I call this person and get a hold of them, see where your residential referral is. And so that also just makes it so much more complicated.
Yeah. And, you know, we talk about these spaces, the IRTS facilities, right? The treatment facilities. This has come up before, right? These other spaces that people are maybe receiving care in, behavioral health care, mental, you know, sort of substance use care, whatever that looks like, hospitals, right? Lots of our folks are in hospitals going through, you know, some pretty significant treatment. And then they come back out to what? Right? I mean, I cannot tell you how many times how many of my the folks that I have worked with have gone into with a lot of coaxing and prepping and everything is going to be okay and support, have gone in and done these sort of really significant hospital procedures to save their lives and come out back to the street and then just had to keep going back in. Now there's an infection. Okay, now, right, now it's septic, right? I mean, what we're talking about is long-term care. How do we provide those supports and then support after those supports and support after those supports and support after those supports, right? And a lot of people are going to be able to do that on their own, right? A lot of people will, but there has to be a bridge there, right?
Hand it to Tatiana next because I think that this segues really well into your work. Before I do that, I just want to quickly come back to something that you mentioned a while back in this conversation, Kyle, is the kind of the algorithmic nature of service provision right now and the real harm that comes from that. And I'm just thinking about how some of our technology is so inadequate. Why don't we have these shared systems? Why don't we have the ability to get information from Minneapolis to St. Paul and St. Paul back to Minneapolis, but we have an algorithm or some AI bot telling us whether somebody is worthy of treatment and care. And I think that we getting our technology right in this space and investing in the technology that works while not outsourcing to the technology that causes harm is a challenge in many areas right now, but it seems particularly relevant to this conversation. So
Molly, I could really talk about this because when Ring cameras first started, a lot of people were saying there's unsheltered people in my backyard. And I was like, okay, this is the start of surveillance in so many different ways. And the ways in which that you are doing this because you are concerned about someone having the audacity to be unsheltered in public. And you don't want it on your sidewalk. And so now you're monitoring this. And then all of a sudden, the police have access to this. Corporations have access to this so they can track your spending. And now in the middle of the ICE surge, everyone was really just having this conversation about this is invasive. Flock cameras are invasive. And I was like, it started with you wanting to monitor your unsheltered neighbor. And so technology in this way is something that also it just continues to create gaps. I'm working with a lot of folks right now who are coming out of incarceration after 20 years, and what is even a cell phone? And so now all of a sudden you have this AI system that is able to track all these things from other states that they weren't supposed to. And then also is putting people at risk because databases are now available to all the federal agencies when they weren't before. And so, as a treatment provider, when we think about, oh my gosh, so the DEA and ICE and the FBI are all together and I can't distinguish who is doing what, everything is scary. And it should be, but it also is just this conversation about like we have to be able to be in community and deal with this discomfort, because if we allow this one thing to happen, all of a sudden it's in our back door now too.
And another challenge with the data collection, right? So a lot of it is checking boxes and funder required, not really improving the quality of programs and improving the condition of the individual that we're serving. So we need to create systems that do that allow providers to communicate with each other and understand what's happening, to not re-traumatize an individual for having to tell their story over and over and over again in each county that they go to in hopes that I am homeless enough to get added to the wait list.
Well, and when the CADI waiver, so the Community Access Disability Inclusion waiver, the assessment waitlist was a year. I had a lot of folks who were like, I desperately need these services in my home. So they would try to waiver hop. So they would go to Winona to go to a different county where maybe the waiver list would be faster. And then all of a sudden they need to come back to St. Paul because this is where your people are. And now your benefits are in 3 different counties because you also tried Cass County just to try to get services to live. And so it becomes unbelievably complex in regards to all of this and the lack of communication, because you did the assessment. Can I transfer it back to Ramsey County in time and have it accredited so you actually can get the care you want in the space you need to live?
I think I've been doing this whole bounce just to get a family into shelter.
Yeah.
So we know that Hennepin County has a right to family shelter. If you are a family in Hennepin County and you need shelter, you can get shelter that night. They have to shelter you, right? And that's not true in Ramsey County. So a lot of what I try to do is establish, do you have a Hennepin County tie? Can we make a case for you as a family, as minor children outside? Can we make a case for you to be sheltered in Hennepin County? And I'll tell you, it's really hard because because that's a big ask of them as one of the few counties, maybe the only county in Minnesota, don't quote me, that has a right to shelter for families, right? And so even outside, just going indoors where it's safe for children is a whole process right now in Ramsey County.
Don't worry, we definitely will not quote you on this podcast. There's so much here, but I want to make sure we get back to the recuperative care conversation and the pick up on the thread that Seneca brought up about people who are getting necessary medical care and then being discharged to go where, and the challenges that those individuals are facing, and also what some of the solutions might be. So Tatiana, I'm going to put you on the spot on this one.
Oh, I can talk about recuperative care all day. That's how I got into this group of women here. So 5 years ago, I joined Catholic Charities to run their recuperative care program. And the program that is there right now is currently funded by the downtown local hospitals, and it was intended to reduce emergency room visits or overuse of acute beds, which can cost hospitals $2,500 to $3,000 a night. And instead, we came up with a model that was more like, $300-400 a night, because we found that You may just need a place to get wound care after, you had frostbite or your diabetes is unmanaged. And then we have the Minnesota Community Clinic that is right downstairs, and you can get them connected to a primary care physician and get them connected to community resources that they need. One of the most important things for me was to ensure that everyone could have this benefit, not just individuals that are coming to the downtown St. Paul area. How do we create more programs like this? So working on the committee to make this a approved Medicaid funded service was extremely important to me. I was hoping for a model more similar to what they have in California, and I know California has diversity in programs, but one that is collaboratively funded by cities, hospitals, counties, that anyone can receive services, no matter their payer, and it is person-centered based on the need, so it doesn't have like a hard cutoff.
Can you say more about that person-centered and sort of what the hard cutoff versus the person-centered model
Yes.
looks like?
So that's what I was going to jump into. So what passed in Minnesota, again, very grateful for a model that has allowed other entities to develop these programs and support communities that are in need. But right now in Minnesota, you have to be eligible for medical assistance, so MA or Minnesota Care. If you're on MA, you need to be at least 19, and Minnesota Care 21. You have to be discharged from a local hospital or have something written from a provider saying that you have an acute medical or mental health need, and you're also unhoused. So those three things are necessary. And you can stay for 30 days, and then with doctor approval and proof of medical need, you can extend that an additional 21 days, up to 30 days maximum. You can stay if your issue does not resolve within that time. Most people re-enter the hospital system and kind of get a new referral. This model is intended to address overuse of emergency room visits and kind of reduce some of that strain. But the housing stability piece seems to be missing because the population that we serve, we can't resolve their housing instability or even their health instability within 60 days. Most individuals who need a waiver need 8 months up to 12 months to get a min-choice assessment. Let's hope that they're receiving Social Security, SSI of some sort. Otherwise, they have to go through the state medical review process. So those are barriers. So right now, you have to have medical assistance. You have to be an adult, essentially, because now, as Seneca is talking, what happens to a mom that has children that has now fallen ill or needs recuperative care? Does she have to separate from her children in order to go into a facility to get the care that she needs? What do we do with that family when the parent needs recuperative care? So there really isn't anything to support a family when one of the adults need that care. After all of this work, stepping away from my current role, wanting to go in and develop a very strong service similar to the one that I have, worked on at Catholic Charities, to find out that this service is now added to the 14 most fraudulent services, which all 14 of the services, I would love to see the data that supports that these services are fraudulent. I believe 3,400 providers had their licenses paused, and I think only 52 of them needed to be looked at deeper. But what that resulted in is the people who needed to be served lost their services and could not connect with their providers.
That was an AA model, just so you know.
And right now, you have providers, especially smaller providers, that have programs that are open, ready to go. They cannot bill for services. They do not have an approved license, and they're bleeding money. So that means that we're going to lose more providers. I am a credible provider who actually did the work to ensure that everyone in the state can have this service. And then there's no exception process as well. So there's a moratorium. There's supposed to be an exception process if there is an unmet need or a great need for it in the community, but yet and still there's no guideline of how to submit for that and what information needs to be submitted. So it's very frustrating because we have lots of individuals. We see an increase in chronic homelessness. So most of the people who are entering recuperative care have a chronic illness and are entering the hospital because of some exasperation of that, and it's being called an acute illness. And then they just kind of recycle back and forth. Right now, you're going to see more individuals going into shelter, not getting access to wound care, because right now, there's no downtown clinic for an individual to access for wound care. That means that our emergency rooms are going to feel the strain. And so I've been continuously reaching out to different hospitals to say, hey, I know that there is this benefit and there's a moratorium, but where are you guys at? Because I know that you guys will feel the pinch. Are you interested in funding this program? And not only funding it, but funding a model that is intentional about supporting this community, because 60 days is not a realistic amount of time to support individuals who are highly vulnerable, have extremely low income, and that often are justice impacted, which means that they now have limited to oftentimes no housing options. So you really need time to work through all of those barriers, and housing ends up being a much longer term goal than them. What we're experiencing now with the current recuperative care model is wash, rinse, repeat. There also is no solution for individuals who do not qualify for medical assistance. We're seeing the highest increase in the aging population. And those individuals are Medicare Part A or Part B, and as such, they do not qualify for that benefit. And they're the most medically fragile. There are not enough bottom bunk beds in shelters to support that need. Last year, during the winter warming, we had people who were in wheelchairs sleeping in the St. Paul Sheriff's Lobby because we had no accommodations for people who needed a bottom bunk or accommodation for someone who had limited mobility. So right now, again, very grateful for this service, but we now have some providers that are able to offer this service. We have a small provider in downtown St. Paul that offers 10 beds, but there are no other recuperative care options in the downtown St. Paul area. And also, how are they determining what makes this a fraudulent service? So I would be very curious. And I don't believe, has anyone gotten any sort of answer about why these specific services qualified as those that are most fraudulent? And they're the ones that are most used by the populations that we serve.
There's so much there, and so much of it is, I think, going back to what we've talked about the need to listen to the people who are using these services, listen to the people who are experts in their own experiences, listen to the data. When people tell you that it doesn't work for them to be in shelter if they can't access a bottom bunk, then it doesn't work to just put in a bunch of bunk beds. If we're hearing from people who are doing the work to provide the recuperative care that 60 days isn't enough, then we need to figure out how to build a different model that allows people to stay until their health needs are truly resolved, until their housing needs are truly resolved. Because again, otherwise we aren't solving for anything. We aren't making people's lives better. We're slapping a Band-Aid on something, and sometimes a Band-Aid is better than nothing, but that is not what our North Star should be.
And the reality, I just wanted to add one piece. Speaking of Hennepin County does fund a 30-bed recuperative care that is located at Endeavors with Catholic Charities and Healthcare for the Homeless. So this is not an uncommon idea. So when we're talking about housing stability, recuperative care needs to be a part of the continuum.
They also, Fairview Hospital also
With our
buys,
saviors.
buys beds at Our Saviors, has so many beds. I always want to talk about, like, I don't want to come in here and put blame on people and on systems that, right, we don't have enough of things, right? But when when I am meeting with somebody who is sitting in a wheelchair that's too big for her to push, and she's been sitting on the same corner for 2 days because she literally can't move. And I say, hey, we need to get, why didn't you get some respite care after you had the surgery? And why are you in a wheelchair? And then I call the hospital. This just happened. And then I call the hospital and they say, if you want her to go into respite care, she needs to come back to the emergency room and she needs to be seen again. And then we'll have that conversation. I'm like, why now we're going to spend more emergency room dollars, right? More taxpayer dollars because there wasn't space for her that first time, right? And so I think we are always talking about funding. We're always talking about spending, right? But we need to look at, what does it cost for an ambulance? What does it cost for an emergency room visit? What does it cost for a night in jail? Right? How can we offset these things, right? Because we're not talking about spending more in the long run. We're talking about spending less by funding these services that people need.
And that's another great point. And you and I discussed this, Molly, the need for community referrals. Seneca, we have a person who recently discharged from the hospital, so they have documentation to show that they were recently hospitalized. We have a provider who has years of experience that can identify that this individual has the need. Seneca should be able to make that referral using the data that was available. That is a fair model because we are subject matter experts. And if a person is visibly in need of additional care, we should be able to make that community referral. So, and again, no one is saying that any system is like ultimately failing everyone. But what we're saying is that how can the systems work better together to improve the lives of the participants that are receiving the services, instead of the person who's receiving the services having to work so hard to go from one provider to another provider to another provider to get all of their needs met. Because then they give up. They throw their hands up. We see, I can't successfully complete my discharge plan because I didn't fully understand it. So how do we truly support individuals that are experiencing that health instability and that housing instability?
So I also one thing that was working really well, especially during COVID, was when the Opportunity Center second floor opened. There were financial workers upstairs. There were, we had medical providers who were right downstairs. We had probation that would pop in. We had different county aspects represented. So we had veteran outreach. We had, also, I'm trying to think of
Peer supports.
Peer support. SOS, which is the sexual assault prevention folks who could do OFPs right in the space, so order for protection, right? I think that sort of model where everything is right there and you don't have to go to different buildings could be beneficial in multiple spaces. That was a really beautiful thing that I think worked really well. It's modeled also in Arizona and it works really well. And so, a lot of times people will be like, I need a social worker. And I'm like, you know what? I function like a social worker. I am nothing without a financial worker because I can fill this application out for you again. But it would be awesome if we could get your benefits on today and then move through this situation and I can take you to the next stop just to get it all done. Because that's just going to revolutionize things where we don't have wait lists.
I will also say, when we're talking about this is one of the things with the camp community closures that was really big for me. Why are we doing this on our own, right? Why have we decided that St. Paul is going to do this, Ramsey County is going to fund it, right? Why aren't we working with our larger county systems, right? Outside county systems, outside partners, right? Who also may have some expertise that we can bring in, right? Who may also have some ideas and some, why are we thinking so small, both financially, right? We're in a deficit. Why we know that St. Paul, right? We're talking about all of these sort of tax hikes, right? I'm a homeowner here. I have heard about the about the taxes going up. But why are we taking this on ourselves, right? This really is a bigger issue, and we need to not just be working together as providers. We need to be working together as county systems and city systems, and really coming up with some bigger solutions as a state.
Well, and also not to do something to say I did it.
Yeah.
You know, we are moving this, we're addressing this, this is going to be fixed. I think the thing that we often need to do is actually say, let's do this intentionally, let's do more time, and then also recognize that it is unbelievably complex. It's something that it tracks multiple systems, and then also just when we think about people's nervous systems and trauma, it's going to take a longer amount of time. And so I think those pieces also mean that anything within 30, 60 days is not possible. We also need to reward people for trying things. When we think about HSS and the housing stabilization support thing, there were lots of programs that were not great, but there were a lot of programs that did really cool, innovative things. And that system came out really fast. And I'm afraid that we're going to lose the ability to move in this systemic way quickly because we're overly critiquing everything in this way.
HSS was a huge loss for the community that we serve. I started this work years ago in the parent service, housing access coordination, which was a home and community based waiver service. So HSS was a way to expand that benefit to anyone who was receiving medical assistance. And what made it a really important service is the transition piece where you are unhoused or unsheltered, and I have this much funding, this much time to help you find housing. And then the second part of it is the sustaining piece, where I or someone stays with you to ensure that you understand how to negotiate with your landlord, to ensure that if you're on some sort of benefit that you continue to show up to your recertifications, you keep your benefits on, you stay in housing, because for most people, getting housed and staying housed is a two-part process.
And for folks that don't speak English, for the first time, they had providers that spoke their language, and so they were actually able to do all of the things that they really needed. You know, the amount of steps that it takes to apply for housing in your background check, and now you have to pay this, and then you need to come in and do this deposit. If you don't have the linguistic support for that to happen, it's not going to happen. There was a lot of flaws. Absolutely, there were a lot of things that didn't go well, but you know, there's a lot of my folks that I support who are housed because they had someone who spoke their language and was able to actually go all the way through the process. And so losing that was huge.
For those who aren't familiar with HSS housing, would one of you be up for just sort of walking us through briefly the history, when it got started, when it ended, a little bit more context there?
So housing stabilization supports was a Medicaid benefit, and we were, I think, the first state in the nation to actually use Medicaid money to pay for housing. 90 days of housing, and then also you had longitudinal access to case management. And that case management could be as simple as, hey, I bought you toilet paper and access to cleaning supplies because your $120 in cash assistance isn't allowing you to maintain your housing the way you want to. So it started and it officially launched in 2021, I believe, and then it rapidly expanded where providers could easily set it up and they would recruit folks and say, hey, I'd love to help you find housing. It launched in the middle of a pandemic, without enough oversight and regulation. And there were people who took advantage of this in a way that was obviously something in the news. And then there were a lot of programs that started to say, hey, like we actually can get this funding for you, or we can be the person that helps you fill out the public housing applications that you need. And then we'll be able to find you because we're in your cultural community, or we are connected to other spaces like the Human Management Information System to help you stay. It officially ended in 2025. It was cut off completely pretty rapidly due to widespread, fraud. There was fraud, absolutely, but I think the response was also really federally pressured to say we're done. And losing that also meant that a lot of folks are actually back out on the streets.
And I will say, many of us were aware of the fraud and who the fraudulent companies were, right? This was part of our provider meetings, right? In Ramsey County, we talked about, hey, this agency feels real shifty. These folks are coming in and they feel like they are sort of predatory here. And these are the agencies that we're working with that are really good, right? We were having those conversations with each other, right? Like the folks that we're working with are getting really, really good services here. And we had lists, right? We were doing that work. All of us were sort of within our spheres, and also screaming to DHS, to DHS, this is scary, right? You really need to look at some of these folks here, not all of them. And I think that is unfortunately what happened is,
right.
Yeah.
I remembered even prior to the pandemic. So I think it was about 2019 where there was a meeting. I was at a library and it was communicated that housing support rate 2, when a person moves into a property, they have to work with that housing provider, and they provide the built-in case management services. And some individuals said that didn't work and they weren't given choice. So that's where they thought that housing stabilization services would be an expansion of that case management when a person is housed, that they could then choose an external provider if they wanted to. And if you were in a specific housing support program, and you chose a different provider, there would be a rate cut. But for the most part, people could have choice. The biggest benefit was also for people who were unhoused, because it also provided moving funds. I think it was at up to $2,000. So up to $2,000, because realistically right now, most people don't have money to move. They don't have money to get things for their first apartment or place, and it provided that. This was also a service that was $15.15 for every 15-minute increment that they worked with a provider. So $68.68 an hour. You are only required to do a free online training and exam on, TrainLink or something, and then pay the application fee. And then I think do some training so that you'll know how to bill for minutes. So again, very low bar. And I think that is because the state wanted to give varieties of providers and take barriers out of the way for providers to start up a new company. Probably not the best process. And then the pandemic hit, and then there was limited oversight because everyone's attention was drawn in different places. So that's kind of the history of it. And again, like Seneca said, like Kyle said, we at every program, we would see these entities show up down at the Opportunity Center. They're walking up. They're telling people nonsense. We would try to turn them away. We would get their information. We would communicate and report. But again, to abruptly just shut this service down means that people who were housed and dependent on the sustaining services, needed that provider to come in and help give them those supports, they lost their they lost their provider. The service is now gone. And programs like shelters are often way underfunded. Funding grants through the state and the city are not enough to operationalize most shelters. So, using funds like housing stabilization services was a way to pay for case management, that we can use those Medicaid billable dollars to then expand services within programs. So, again, it could have been used creatively, but we can't just abruptly stop every single service because of fraud. We need to, when fraud is being reported, there needs to be some immediate response to it, some follow up. We need better oversight and audits and compliance put in place. But the one thing that happened is that to date, none of those things have occurred. What we're experiencing is more barriers to service for individuals who are unhoused or precariously housed.
I think that that's it. I just really want to highlight that, Tatiana, is what we're talking about is a group of folks who really just need a little bit of support and services, who are really struggling. We have a bunch of people who took advantage of them. And then as a result of that, we cut off all of these extra supportive services to those same people who were just sort of exploited. And the people who pay the price here are the folks who are struggling the hardest in our communities, right? And they just keep taking the blows, and that's not fair.
Well, and I think those are also folks who are more likely to end up in an encampment, because why should I trust the system again? And so I really, when we talk about sort of the choice that supposedly people are making to remain homeless, it's, things didn't work out because what I was promised and I had was taken.
I don't think we will be naming this podcast since it is not a real podcast. But if we were, I think listen to the experts is the clear theme from this conversation. I mean, just hearing you all talk about how folks knew that there was some fraud happening, knew who the bad actors were, and knew who all the incredible providers were who were still doing amazing work and not taking advantage of the system and improving lives. It's so infuriating to hear that described and to hear it laid out, and to know that the consequences now are that we're not funding essential care, and that then has ripple effects to people not trusting us. And it's not, we can't just turn that switch back on. We can't reestablish that trust overnight. And that is just devastating.
The betrayal trauma is the term. And it's one of the hardest kinds of trauma to overcome, because the only way you can overcome it is by trusting again. But, I always think about this in terms of, when I talk to someone about like a relationship, if you've been cheated on before, how hard was it for you to trust a new partner? Now, imagine that actually having implications in terms of your safety and security and ability to be in a space where you weren't constantly under traumatic stress. You have to multiply that betrayal trauma by 100, and then this is where we are.
And this is why we talk about time. This is why we talk about it takes more than 30 days to send in. You don't take 30 days and send in a brand new team from Ramsey County to do all of the things that they need to do, because this takes time. And that biggest amount of time is that trust. Sometimes it takes people 2 or 3 years of me seeing them twice a week for them to finally tell me what they need, right? And I'm sure for other folks, it's going to take 5 or 10 years of seeing me twice a week for them to tell me what they need, right? It's not 30 days.
Yeah. I had a client who passed away during the pandemic, and he was someone that I was really close with. I saw him every week for 18 months. And there were 2 things that were super, I think, amazing for me at the end when he passed. One, I never knew his government name. And so I actually didn't know he passed until someone was able to put that in context for me. And the other piece is that he actually had a very prominent mustache that I never saw, because he had to wear a mask that whole time that we were spending time together. but like the idea that I didn't know his real name and we were connecting for sometimes an hour weekly was just so profound. This was someone who was starting to open up, but it was so deeply layered that I, only knew him as a nickname, but I knew him. But that's also just what we have to overcome.
I want to go back to something from much earlier in the conversation, a question that I think is for you, Seneca, but want to open it up to everybody. And then a couple of wrap-up questions, and then we'll let you go back about your lives. But Seneca, you mentioned housing first as a model and how it's gotten more pushback recently, and there's been more criticism of it. And we both live in Midway, where this is a huge topic of conversation, where I think we are seeing a model that can really work, and also seeing that it can be challenging for the surrounding neighborhood and result in a lot of different perspectives around whether this is the right model. And so I'm really curious if you could share for folks who are listening a little bit about what you've seen with that model, about what you've heard when it comes to the criticism of the model, and kind of where you think we need to go from here when it comes to housing first.
First, I want to say I think Avivo is doing some really great work. I think we can look at the Avivo Village over in Minneapolis as a kind of an idea of maybe where the kind of shelters we should be setting up, where people have their own homes, like tiny sort of homes within a community. I think community is incredibly important for people, and I think we need to do everything we can to preserve that. And then when we are looking at some of these housing first programs, Avivo's got some, right? We're talking about Kimball Court over here in the Midway that just recently expanded. So Kimball Court had for a long time GRH units, and then got a bunch of funding to open up these PHA units now, right? So it expanded.
I'm sorry to interrupt. Could you just define GRH and PHA for folks?
Right. And I think what is GRH is now called housing support, right? So housing support, the housing support units are sort of think of it sort of like you have your own room, and then there's this sort of shared community space, like kitchen and bathroom, that is, now we're going to ask for all of, that is a third of your income, pays for that. And then the PHA is the public housing. Right. And so we're looking at a couple different housing models there, and different sort of, which are housing different people who have different needs. Right. So it's great. The pushback, a lot of the conversations that I'm sure you are having, Molly, in the neighborhood, and I have been having in the neighborhood, is this idea that that somehow these housing first programs bring in drugs and crime and are sort of these pools for all of this awfulness, right, in neighborhoods. Let me tell you how I have been working with Kimball Court. Right, over in the Midway, we have a large population of folks who are living outside. Right, most of these folks are staying in alleys, in doorways. There are a couple apartment units that are empty, and I won't say where they are, but they are in the neighborhood that sometimes folks will stay in. And then folks are staying in the hotels nearby, the motels nearby when they can. Right? That's sort of what that looks like. And that's it was sort of 60 to 80 people. With the closure of Fish Hatch, we saw sort of an increase of about 20 more people to the neighborhood. So what we did is I worked with Ramsey County, the Ramsey County assessors, and the Familiar Faces team, St. Paul Outreach, and we did a big housing pop-up. So we got all of those folks who were staying outside in that community housing assessments, right, which is where you start if you want to go into the supportive housing. We got everybody housing assessments. And then we have worked with Kimball Court, with Avivo, right? We said, hey, these are your neighbors, right? You are opening up all of this new housing. Let's start with the people outside your doors, right? And they said, that sounds like a great idea. So we have been working together to get some of those folks who are outside already neighbors inside, right? We're not we're not making people stop using drugs. We're not, right? That is not a barrier for them. We're just saying, how do we get you outside, inside? And so a lot of my messaging to the community has been, your complaints are that you are seeing some of this open air drug use. You're seeing people struggle, right? You're just really in general seeing people struggle outside. This housing first provider is helping folks get inside, and that's the first step. It doesn't mean they're not struggling anymore, but it means that struggling to find a place to sleep isn't part of that, right? And then the work continues, right? How do we continue to support, right? So I have been coming in to some of those housing first programs and doing some education around medications for opioid use disorder, right? This is what methadone is. This is what Suboxone is. This is what Sublocade is. This is how we use it. This is how, ask me all the questions, right? This is what treatment looks like, right? This is what IOP is. This is like, let's just ask some questions, right? And figure out where you need support. If you need any of that support, right? If that's a next step. But those housing first programs are critical for my work in doing that wraparound support with treatment, with medications.
So I think the big thing about Housing First is the model, the idea is that we get people housed first. You don't have to be on mental health medication. You don't have to be sober. You don't have to have these other sort of criteria of worthiness to be placed in housing. It is a model that also has a very specific definition of case management. It's also a model that also talks about the ways in which you support individuals. And so I think the problem is that when you have an evidence-based model, is that sometimes it gets rapidly adapted, and then we take the criteria that makes the model successful, which includes staffing ratio, which includes case management, which includes connection to outside providers, and we say, we're housing first, but we don't fund the rest of it. And so then all of a sudden the evidence-based components of it are not there. And so in terms of what's happening is that whenever I see conversations about housing first, it's taken out of a context that says, hey, housing first also includes case management, it includes continuous long-term support. It also includes boundaries on behavior. Harm reduction doesn't say anything goes. It says, I care about you. And I absolutely do. This conversation needs to be about how we can stop this problematic behavior from happening and keep you housed. And that includes staff and relationships. And if that's not part of the funding model, then it's not housing first, it's housing. And that's sometimes what I think people are seeing. And Seneca is part of that continuum of care that needs to exist. The hard thing is that we're funding half of it. We're not adhering to the evidence base, and we're not making sure all of those conversations that also include these people are your neighbors. It's not someone else's job to engage with them. It's all of our jobs to say, you're welcome in my neighborhood. I want you to be here. But as part of being here, let's be neighbors and make sure that we're cleaning up our own litter. We're having these conversations. And when you are invested in your community because you know you are welcome in your community, you're more likely to be able to engage in that.
I just wanted to say one thing. So when I was a housing provider, I was a housing first provider. So that is a state fund supplemental income that will pay, room and board up to, I think right now, what is it, about $1,200 completely if you have no income. But if you have passive income, Social Security, VA, with Social Security, I think now it's 30% of your income. If you're working, it shifts depending, and you have to report your income. If you have other passive income, it will take all, but what do they call it? Special needs, personal needs.
General assistance.
Yes. So whatever your general assistance is, it subtracts that amount and gives you a fixed dollar amount. So for a while, most people on Social Security did not want that benefit, but we all as advocates went to the Capitol, advocated for that 30% to be in alignment. as a housing first provider, that is to be a provider of GRH housing support, it says that you have to follow that evidence-based practice of housing first and harm reduction. However, there is no training for that. There are some great videos on YouTube that I use to train my team. And it was really around that choice too, right? So with case management and housing first settings, a participant can choose to engage or not engage. You cannot force them to participate in service. But as a provider, you get creative, right? You find ways to engage. There are funds that you can use towards like bus cards, things that you can use to enhance engagement. I used to do a barbecue, pizza party, community meeting, letting individuals have voice in the process. And
Food.
actually,
Food is the important.
all the time. They called it the pizza meeting, but housing support does require you to have community meetings and 2 community engagements a year. So when providers are taking these state funds, they should be fully executing on what the model is. There needs to be better training. If the state is going to say, you're a housing first provider, define what that looks like, other than a case manager has to attempt to meet with someone. I think it's at least once a month.
I know. I think so.
Yeah, once a month. And I know that because I used to require my people to do twice a month because there was a 50% chance of them connecting with the individual and then having a documentation of that record. But I say that to say again that then organizations then take this funding and then decide what housing first means to them and what harm reduction means to them. And that has been like my biggest challenge. What does harm reduction mean? Is it clear to the guests that we serve? It doesn't mean that everything goes. Some places want to do measured pour programs. Some places want to just kind of have individuals be able to do community meetings and have say. But again, what does harm reduction mean? How are you applying it to your program? And having that clarity and then making it clear to the people that we're serving, and then also communicating that out to the community so that we don't continue to have these NIMBY issues, right?
And I think what we are just talking about some struggling people. We're talking about people who are struggling. We're talking about a lot of people who are going to be struggling for a while, right? We're talking about people who are struggling and who are going to go into housing and struggle, right? And that is the question. How do we create some compassion around that? How do we not turn that into, how do we talk to neighbors about that? How do we, right? I don't know. And it's frustrating because, again, I think I keep seeing the sticker. I don't know how I can convince you that you should care about other people, right? I'm going to try. But housing first is not the end of it, right? None of it is the end, right? We're talking about a really long continuum, and we're talking about people really needing to care about people they have been told they shouldn't care about. Yeah.
I think that is so well said. And the point that I'm hearing over and over again is that housing first is what we call this housing model. It isn't the entirety of the policy. It isn't a full description. It isn't the end of the conversation. It is the start of the conversation. And that I think when we talk about what are community misperceptions, how can we do a better job of bringing people into understanding so that they can then become supporters and champions of providing this care and this housing for their neighbors, for their community members. I think really clarifying that is so helpful. Of housing first, there's a whole bunch else that comes with it if we are going to follow evidence-based practices.
I have a recommendation. When I was operating programs at Catholic Charities, and I would have staff that had a lot of challenges with working and supporting individuals who use substances. I called in my friend Kyle. and she has a training that she delivers. Is it supporting individuals?
Yeah, or drugs and why people use them. Yeah.
Yes. And I think that those should be like good community ways to educate people, right? Because I think one of the way that it started, and this was important to me because I grew up in Brooklyn, New York, in the crack era, right? So I think Kyle starts off by saying, what is the difference between cocaine, powdered cocaine, and crack?
Baking soda.
And it's, I think most people associate like crime with crack and like poverty and this. And I think her response was, it was like a racist response to like criminalize certain populations. The drugs actually operate in the very same way. Um, and those kind of things, this was staff who was supporting individuals who used drugs but did not know that difference. So we have a lot of individuals that are hired to execute, that are expected to give like really great mental health guidance to populations that they don't have any formal mental health training. They barely know how to respond to crisis when it comes up. So that not only that community education, but also how are we educating and supporting the individuals doing the work? Yeah.
No, I just echo this, and I want to say, as someone who taught an LADC, so alcohol and drug counseling programs, the first thing I would do is teach my students how to use drugs.
Yeah.
Because most of them had never been exposed. You know, I got thrown into my practicum, and my first day, one of the things that happened is someone broke a crack pipe over my head, and I didn't know what it was. And I was at the point in which I was supposed to be serving clients. I was lucky enough to be radically humbled and have people with lived experience say, "Hey, white lady from the suburbs," which is very true. "You don't know what you're talking about." And I was like, "Okay, let's talk about it." And I think that is something that is so fundamental. We're stuck in theory as opposed to practice. And then the idea is again, going back to the radical empathy of this makes sense. You don't like it because it makes you uncomfortable, and we've been told this is still a moral crisis. But what they're doing is actually logical. Until the housing is there, treatment doesn't make sense. But yes, also thank you for plugging my training.
But we need more community education, right? If you go into your local community ed book, you can take a cooking class or a sewing class. I think people need to take some Narcan training or some how to respond to mental health crisis so that it's clear that this is a community issue and concern, and it's not one organization's responsibility to manage that. It's not the police's responsibility to respond. These are neighbors. Individuals are going to experience mental health breakdowns. I just watched my own city, well, my county, Santee County, where a gentleman opened fire on a community just a few days ago. And as I'm going through the Facebook comment, all that I saw was he was a pastor. He must have had a mental health break. I was very happy to see that the community cared about him, and it was not just bad, negative comments, and they really wanted help. But how do we give that same care when you don't know the individual?
Well, and I will say, and I'm going to plug them because I love them. I co-chair the North Minneapolis Harm Reduction Coalition, right? We are a group of providers, a lot of medical, a lot of the neighborhood clinics, a lot of neighborhood organizations, outreach, we run the gamut, right? There are 18 agencies, including MDH and DHS involved in that. And one of the things that we did in the community there along West Broadway is we started working with businesses. So we said, okay, we're seeing a huge rise in overdose deaths. What do we do about that, right? And so we started going from door to door, and we worked with businesses. We put these signs in the windows that said, hey, you can get emergency naloxone here, the business owners. And then we started training the business owners, right? Because they said, well, I'll take this Narcan, I'll take this naloxone, but I don't actually know what to do with it. And we're like, great, let's, right? But I think it is, we have to be hitting the streets. We have to be talking to our neighbors. We have to be talking to neighborhood businesses, right? This is how we do it. It doesn't work if we sit in our offices, right? It doesn't work if we sit in buildings. It doesn't work for us to connect with people who need services if we sit and we wait for them to come in, because as Kyle said, betrayal trauma is real, right? You got to go out and you got to build those relationships, but not just with the people that we are serving. We have to do that with our neighbors, with our businesses, right? Again, this is a community issue, and we need community to be involved in solving this, right?
50 million more questions, and we could talk, I think, for many more hours. I just want to give everybody space, sort of final thoughts, anything that you want to make sure you share before you walk out of here today.
I think the biggest thing is that homeless people or individuals who are unsheltered deeply care about their health. They are doing things in a way that makes logical sense. And, I think one of the pieces that was revolutionary for me in my practice, but also just in my life, is that there's a culture of homelessness that we need to understand and be culturally competent in, and that includes everyone who's doing an intervention. And there's also a culture of drug use that we need to respect. In the world of drugs, as there are right now, there also may be people who are not leaving and not stopping use because they are literally keeping their family alive. Overdose is real, and the folks that are reversing them are the people who are using. And so it's not just as simple as the end, but knowing that you actually are carrying the lives of the people in your community on your back, very literally, is huge. And so I would just really encourage individuals to take a breath and ask themselves, am I uncomfortable or am I actually unsafe? Because most of the time it's really the first. And discomfort is actually something that can propel us into curiosity and change if we let it. So sit with it.
One of the things that's important for individuals to remember is that homelessness is a symptom of a bigger issue, right? And I know that when we're talking about systemic issues, it feels like, a big, hairy, audacious goal that no one wants to address. This is something that we have to address as a state, a city, a county, a neighbor, providers. This is all hands on deck because it does affect everyone. And substance use can't just become an issue when it impacts someone in your family, right? We have to look at everyone because we're all responsible for each other. Until everyone is comfortable, right? We all need to be uncomfortable. And it's not a us versus them. Homelessness is not an unsightly problem that no one wants to address because it may end up in your door, at your front door. And if a person who is unhoused shows up at your door, they're more likely wanting to help to cut your grass or do something for a couple of bucks, right? Than steal something from you. So one of the things that has been most impactful for me is learning, talk to someone, have a conversation with them, get to know them. I have met individuals that are musical, that can take anything apart or build anything. These are real people that have real lives that are going through some things, and we're also experiencing some things as a country right now that may also drive some of the stress levels that increases use. Mm-hmm. So we're not addressing that, but we want to address the user.
I often think about, right, I think about how in my work, what is the kind of the trade, right? Like what does that transaction look like, right? What am I getting also? Because I think it's really important for folks that I am working with to also be giving to me, right? And the thing that I come back to over and over and over again is learning what community care looks like. The folks that I work with are consistently teaching me about what community really is. My house neighbor next door to me doesn't know what size shoe I wear, right? Or what the state of my shoes is. But I can go out onto the street and ask someone, hey, I noticed so-and-so's shoes are falling apart, right? They're like, they wear a size like this. This is their favorite shoe. This is their, right? People know, they know each other and they take care of each other in that way. And I think we can learn, I think folks who are stably housed can learn a whole lot about what community and community care looks like from folks outside. And with that said, any interventions that we do on a city level, on a county level, on a state level, have to take community into account. This is how people survive, right? There is no solution unless we are looking at community solutions.
And homelessness is a housing problem. It's about availability. It's about affordability. It's also just about being able to pass a background check. And when we look at vacancy rates, they're really low. The other piece is that a lot of folks don't actually become homeless because of mental illness or drugs. It's a condition that develops when we put people in situations that are uninhabitable.
I cannot thank you all enough for being here and being a part of this conversation, but far more so for all of the work that you do every single day. We are so fortunate to have you all and Kat and all of the incredible folks in our community who are tackling big systemic failures and every single day working to make people's lives good in spite of our systemic failures. So I am so grateful. I also just want to say a huge note of appreciation to Bonnie and the team at the St. Paul Neighborhood Network for hosting us today and allowing us to record this conversation. I think it's so essential that we make space and have platforms where we can have these more in-depth, robust conversations, because we are not going to solve for generations of systemic failure through it's not going to be easy. It's going to be hard. It's going to require us to dig into what's been done and what can be done differently, and to learn from the experts. So super grateful that we have this space, this incredible community asset where we are able to record conversations like this. There's a lot of work ahead, but I think that really this conversation is pointing us in the direction that we need to go in as a city. So I really appreciate it.